Welcome everyone to today's webinar. We'll get started in just a minute. We'll wait till the top of the hour. Thanks for being here. Welcome. I'm seeing more people log in. It's so great to see that participant number go up, and we're glad you're here. We're going to get started in just a minute. Welcome, welcome. We'll get started at the top of the hour. Thank you for being here. Welcome, everyone. My name is Katie Beachy, and I'm the Strategic Director for Comprehensive Cancer Control Initiatives at the American Cancer Society. And we're so happy today to bring you this webinar about advancing HPV vaccination equity. In a previous life, I was the director of a state cancer coalition and really enjoyed working with my partners in the immunization field on HPV initiatives. That partnership was strong. We collaborated on many things. And one of our favorite places to go for information were roundtables. And the National HPV Roundtable has been so supportive in this webinar development, and we're happy to partner on it today. But we're bringing this to you thanks to our friends at CDC, who ACS is in a cooperative agreement with them to provide training and TA to cancer coalitions across the country. The National Comprehensive Cancer Control Program has 66 such coalitions, so we hope many of you are listening in, and we'll walk away with some concrete strategies that you and your coalition can do to advance health equity in the HPV vaccination space. And now I'm going to hand it over to my co-moderator, Kiera Long from the Roundtable, who's going to introduce herself.
Hello, everyone. My name is Kiera Long, and I'm the program manager for the National HPV Vaccination Roundtable. And I just want to welcome all of you, and we're so happy to have you today. So during today's session, you can expect to learn some things that we'll be doing is highlighting HPV vaccination related policies that are currently being worked on and are key to impacting increased HPV vaccination and decreasing the incidence of HPV-related cancers. We hope to share examples on how to advocate and engage in advocacy, action, and activities that partners can employ to advance HPV vaccination equity. And we also want to highlight the work with African American communities and minority populations relevant to HPV vaccination and how we can improve vaccinations for those populations.
Awesome. Thank you, Kiera. Just have a couple housekeeping items for you. We're going to record today's seminar. In fact, I think Gabby already got that going for us. The link to view this will be sent to you after the webinar, anyone who's registered. And if you have any issues during the seminar today, could you go to the next slide, Dee? If you have any issues during the seminar today, please reach out using chat so that we can make sure that we're helping you. And just to make sure we don't have disruptions, we have muted you. Don't take it personally, but we just want to make sure that we have clear voices coming through and no background noise. We will have two speakers today, and we will wait until the end of the presentation to take questions for them. Back one slide, Dee, I forgot to give a formal shout out. Today's webinar is supported by the CDC, by the National Comprehensive Cancer Control Program, but the content is not, doesn't represent necessarily their official views. So we're very appreciative to their support. Okay, go to the housekeeping slide, and then I would love if Christine would pull up an icebreaker. Our first poll is a silly icebreaker just to shake off whatever's been going on for you today and dream about what you can do or what you always hoped you can do. We've got a silly icebreaker for you. Which of these uncommon superpowers would you like to have? You can launch that poll. And I think that these are hilarious. You have to scroll down to see all of them. Sleep suppression, so that you wouldn't even need sleep. You could just be awake and alert all the time. Have a gut that could have anything. I think Gabby and I might both click that one. An indestructible digestion. Ooh, change the weather. I love that. I live in Kentucky and I always want it to be less humid. If you could talk to animals, I actually think I already have that superpower, but if that's your jam, go ahead and choose that one. Or the ability to translate any language in any form. That would be awesome for traveling. So I'm going to let a couple more people fill that out. What do you think your superpower could be that you would just love? I think some of us like to sleep because we don't really want to suppress the ability to sleep. It looks like a clear winner is ability to translate any language, but we'll give it just another second. What was your be, Kiera?
I could definitely go for the indestructible digestion for sure.
Yes. If only I could eat all the fried foods I want to so badly. Oh, this is fun. Okay, go ahead and show us who's answered so far, and then we'll move forward. I love it. I love it. So everybody, we've got some linguists or future linguists on the phone. I don't know about you, but I do Duolingo just to try to keep the synapses firing. So thanks for sharing. And we're going to do one more poll. This one's a little bit more serious, but nonetheless important. Since we do receive funding from CDC, and just because we are good public health folks, we want to do a pre-post today. So if you'll indulge us by taking this survey, it's just a few questions, 6 questions. I'm going to give a little bit of space here for you to scroll down and take those questions. So we'll allow there to be a little bit of dead air while that happens. But it's super important for us to know how well we're communicating and ways in which that we can do our communication better. So take a minute to answer these questions, and I'll be quiet for a second while you do. I always think about having music, Kira, but then I forget. I bet the round table would have music.
You need something fun.
I know, but we do appreciate you guys taking the poll. We'll give it
We
just
could
another
we could
minute.
hum. I'd rather not.
People don't want me to say. All right, looks like we've got about a quarter of people have finished. I'm going to give it just another minute. Thank you all for bearing with us. If you're just joining us, we're doing a poll, a pre-webinar poll. If you're having any problems with it, just let us know in the chat. Make sure you scroll down for all 6 questions. Awesome. What I'm going to do is leave the poll up for a second, so you don't need to close it, Christina. But if you personally have finished taking the poll, you can click on the minimize button at the top. And then we'll get started. So take your time with the poll. It won't be closed for another couple minutes, but if you'd like to get rid of the poll on your screen, you can just click the minimize button. All right, next slide. I'm going to hand it over to Kiera to introduce her colleague and get us going today. So thank you.
Thanks, Katie. So we have 2 speakers for today, which I'm very excited about. Our first speaker for today is Dr. Jennifer Cunningham-Erves. Dr. Erves is an associate professor of health policy and the inaugural director of community engaged research in the Office of Health Equity at Vanderbilt University Medical Center. She is a public health oncology behavioral scientist focused on cancer prevention behaviors and lowering cancer disparities. Her current research focuses on improving HPV vaccination uptake among children and adolescent populations who have parents with concerns about the vaccine. In addition, she researches strategies to advance community engagement and improve clinical trial recruitment and retention among unrepresented research groups. She also works on national and state level committees, researchers, as well as community-based organizations and members to develop strategies to reduce disparities across diseases. Welcome, Dr. Erves.
So good afternoon. Thank you for the opportunity to be here. So before we get started, I would like to share these quotes with you. These are quotes that I have directly received in doing research. And these quotes really demonstrate the inequities that parents face, especially in the African American community when it comes to getting the HPV vaccine. So I just want to give you one moment to look at these quotes. So each and every day, someone is faced with an inequitable experience in healthcare, and with HPV vaccination, there's no difference. So when you look at these examples and parents, when they speak about their experiences, you see that their experience differences whether it's in communication, whether it's by race, by gender, in terms of access, it is very much prevalent. So before I get into talking about inequities, I first want to just take a look at HPV vaccination rates overall and by race. And when we look at these figures, we know that rates are at 62% in terms of adolescents being up to date, which is still suboptimal with the national goal of 80%. But when we look at this visual, we see that among African Americans specifically, adolescents, about 77% have initiated the vaccine, but yet only 59% are considered up to date. And so we still have a long way to go. So when we think about immunization inequity, this is a major contributor to suboptimal rates among African American in general, whether it's adults and even here in children. And so when we think about immunization inequity, this is the systematic differences in access to HPV immunization among adolescents. The biggest thing about this is that it can lead to unavoidable and unfair differences in health outcomes in communities. So, for example, for a long time, we've known that African American women continue to disproportionately be impacted by cervical cancer, having the highest mortality rates. And a lot of this contributes to structural racism inequities and including immunization equity for HPV vaccination. So these inequities are primarily attributed to the inequities that we have in social determinants of health. It's a major driver in the HPV vaccination rates in terms of initiation, completion, and disparities of why they exist. So when we think about social determinants of health, these are the conditions and the places in which people live, the way they learn, the way they work, play, and which affect health risks and outcomes. And we know approximately 80% of the percentage when it comes to social determinants of health actually contributes to people's outcomes. So when we think about social determinants of health, we're thinking about education access and quality, healthcare access and quality, neighborhood and built environment, social and community context, economic stability. All of these factors are very critical when it comes to individuals' outcomes. They can positively or negatively impact health equity. And so addressing these social determinants of health is a primary way to achieve health equity. So I wanted to bring these some of the work that has been done to the forefront to really understand how these inequities and social determinants of health actually contribute to the inequities we see in HPV vaccination. So what I did was I took the social ecological model. This is a model that we all are familiar with, and it shows how different levels of influences can actually impact one's behavior and subsequently their health outcomes. And so in looking at this, I really want to start with the policy level. This level is very critical when we talk about the inequities we see in HPV vaccination. These are your upstream factors, such as policy and how it affects economics and social influences, and how they actually impact one's outcomes when getting the vaccine. So when we think about structural racism, discrimination, we think about HPV vaccine politicization, the lack of access that people experience because of these policies, the biases that are present when people make the decisions around around vaccination. These are critical factors that really negate how things happen downstream and contribute to inequities. Not only that, when you think about the community level, it has stimulated for many years medical mistrust or lack of trust in vaccines and science at the community level. And we can honestly say, based off some of the data, that the COVID-19 pandemic has further fueled some of the community norms at this level. Also, at the institutional level, when you think about the organization, schools, and workplaces, particularly when we think about the medical home, the lack of access, the the times being offered, parents can't get off of work, can be inconvenient at times. Not offering the vaccine, the quality of the medical care, insurance, based on insurance. These things impact people's views and how they receive care around vaccines and HPV vaccination. When we think about the interpersonal level, the lack of a recommendation from a provider, the poor quality communication, the social networks that are fueling the hesitancy or the beliefs around vaccination, the provider biases, all of these are very important because the literature shows that the African American population are more apt to receive or experience these issues when it comes to healthcare in general, but as well as HPV vaccination. And also at the individual level, vaccine hesitancy is very critical. The lack of knowledge, lack of trust in providers, lack of insurance, transportation, location, urban versus rural. All of these things are very critical at the individual level when it comes to creating inequities around HPV vaccination. And so I really want to hone in a little bit on provider recommendation and communication because we know in addressing upstream issues, it can take a little longer to address, but the providers are very influential and they can play a very important role when it comes to getting parents to get the vaccine. Studies have shown time and time again they are the most influential factor in parental uptake, especially if a parent trusts the child's provider. However, when we look in the literature, we see that African American parents are less likely to receive provider communication and less often to discuss the vaccine in a clinical counter. And we see that there are disparities existing continually around these recommendations. Other studies have identified the issues surrounding communication, the over sexualizing of children during the recommendation, feeling of being offered too early, female focus, less quality of care due to insurance. That's all of these things are very critical when it comes into the encounter when you think about providers and recommending the vaccine. I want to just highlight a little more detail around clinic experience among African American parent-child dyads in a study that we've done. And what we found is that when it comes, especially to those who were unvaccinated, all of them really did not receive a recommendation or the discussion around the vaccine in which they perceived they should have received the vaccine, which was very critical because the parents often stated that I look to providers for a certain way that they should recommend or introduce vaccines to me. And I want to have a discussion with my provider about these vaccines. And so, but as you notice, for those who had initiated and even had completed the series, that the more apt that they had a recommendation and discussion around the vaccine, they were more apt to complete the series. So this qualitative study just kind of confirms what we've seen all along, is that recommendation and discussion is critical. So in absent of these recommendations and the discussion, we can see why uptake can be lower. Also, something that was important was to receive supplemental information. A lot of times parents would like to confirm what providers are actually saying to them. They would like to look to an outside source, whether it's a brochure, web page, and also getting this information pre-visit was very critical for parents so that they have time to go through it, either get their questions answered or be prepared to ask questions for a provider. So this is very timely in knowing that providers can play a key role in getting information prior to a clinic visit to aid in the clinic visit, but also to get parents the answers that they deserve. And then also one final thing to point out is that a lot of times when we have clinical encounters with parents, we think that once we start the vaccine that and we give them that information, that the education stops. And one thing we notice with these parents is that at each stage of the process, yes, similar things parents wanted to know, but over time, parents still wanted to know different things at each phase. And that's really interesting in that we need to be prepared to still answer questions on the vaccine, even after a parent has fully vaccinated their child. And when it comes to information type, a lot of times we target our parents in clinic visits. And what we found is that parents want information that's more family centered. They have a lot of talks at home, which actually reflects the African American culture in terms of collectivism. Everything is centered around family decision making and working together in different times and in different things, including health. So that's something to take into consideration when we think about being culturally sensitive. Also, tailored messaging, pre-visit, and use of graphics to increase health literacy were things that were very critical and needed during a clinical encounter. So when we think about these things and the reasons for the inequities and the role providers can play, there is a call to action here. And this is where we state in which everyone has a fair and just opportunity to attain their highest level of health, including immunizations like HPV. So achieving equity in HPV immunization means several things. It means tailoring services to meet the needs of those who are un and under vaccinated, which is very important because people have different needs, as you can tell. Reducing the risk of vaccine preventable diseases such as HPV and associated cancer among vulnerable communities and individuals who are at highest risk of suffering from these diseases. Contributing to health equity in general and benefiting both the individual and the society at large. So when you think about achieving equity in HPV immunization, it's not just about the immunization, it's about the system, it's about the providers within the system, it's about the people being served, the community champions that can help advocate for change. All of these things must be taken into account when we want to achieve equity. So what are some overall recommendations when we think about achieving equity? Well, of course, we already know continue to advocate for policy change, This is very critical. And it's not just from the immunization perspective, it's the overall aspect of structural racism. When we think about these policies actually impact how one feels, the level of trust, medical mistrust, trust in the providers. These things are critical when you want to build trust so that people can actually accept the recommendation provided. We want to also create the social norms for vaccines and using community engagement in that process. We know that the social norms of vaccines have drastically changed over time. And so community members, community leaders can play a key role in helping to change how the norms for vaccines, including HPV vaccination, and how it exists. We have to be intentional to address systemic issues, the social determinants of health, and vaccine access issues. And we have to partner with the trusted messengers to provide trusted messages on the HPV vaccine. Provider protocols and communication should be inclusive and in place for health equity. And so, what that means is not just providers, but all stakeholders involved have to be very much aware of social determinants of health, how they impact the inequities that exist, making sure protocols, guidelines, services provided actually align with those inequities to actually achieve health equity and increase HPV vaccination. And also linkage to care and services. Although there are policies in place, some kids still slip through the crack. They still are not getting the vaccine. And so it's very important to actually aid in linking to care. So, and when you think about linkage to care, we have provider offices, we have pharmacies, we have health departments. We have also seen where schools have been very effective and impactful. However, in some work that we've done, we also found that parents and children actually have concerns about going to outside sources outside of the medical home, especially if they're not used to receiving care in these areas. And so, for example, when you think about pharmacies, yeah, they may be convenient. They may understand the vaccine process as parents. However, the businesses, they look at it as a business, the lack of privacy, the lack of trust. They don't track records, the lack of continuity of care, disconnect to pay pharmacies. All of these things are concerns that parents may have when it comes to working with pharmacists to get their children the vaccine. And very similarly, parents' views towards health department is still not the medical home. I mean, they may like a medical home, they'll use it, it's cost efficient, it's convenient and track records. However, there's a stigma associated with health departments. Some viewed them as unclean, they don't use reminders, the lack of continuity of care. Some viewed them as not convenient or associated with government. So when we want to educate parents about different areas where can get the vaccine, it's very important to address some of these concerns that parents may have to increase likelihood of uptake, but also work with these different providers so that they're able to address the concerns of parents as well. We also looked at these views from children perspectives, and because we see that the children are playing a role in parent decision making, so it's important to understand their views when it comes to pharmacies and health departments, schools, etc., so that we can be prepared to aid in getting them into care. So I want to leave you with some recommendations for clinical encounters. These recommendations were built based off of some work with African Americans, parent-child dyads, and we applied Matthew Kruder's guidelines when it comes to being to target information, culturally target information for communities. And so the first one is around linguistics and language, particularly being culturally sensitive, being empathetic, using plain language, using definitions so that people have a clear understanding of what the ask is and the information provided is understood. When it comes to peripherals or visuals, parents and children thought videos, brochures, one-pagers, and websites were very impactful and can be very effective when it comes to increasing their understanding around HPV and the vaccine. Evidential. Having evidence on HPV cancers and the vaccine to address parent concerns, using consistent messaging across clinical encounters. I don't know if you can recall back to one of those statements on that first screen. Doctor had told a parent that yes, the vaccine is very effective and can prevent cancer, but came back in the actual visit and said maybe. And so it was inconsistent messaging, which really deterred a parent for completing the HPV vaccine series with their child. Also, using messages that are age appropriate and by sex is very important. Acknowledge for sociocultural, this is the part where understanding the social and the cultural context of the African American community, particularly acknowledging concerns on vaccines and HPV vaccines specifically, tailoring those messages to their behavior and cultural beliefs, being culturally sensitive, being trustworthy. We hear this a lot, but what does that mean? Being an active listener, engaging in co-decision making between parent and the provider. And in some cases, the patient may actually or child may be involved. Acknowledging research history if necessary while countering with research protections today, because there are a lot of concerns still around getting vaccines and the why, and some parents may want to understand the research history and why they should get the vaccine for their child. Recognizing it may take time for a parent to decide to get a vaccine and provide ongoing education on vaccine safety profile, even if a child is vaccinated. So education must be ongoing when it comes to vaccination. Testimonials of providers and other parents on getting their adolescent vaccinated could very much be a strategy to aid parents in getting the vaccine. And the literature shows that this works. Other constituent involving strategies, hiring race concordant providers and staff is very important. Time and time again, the literature shows that the African American community really resonate with race concordant providers and staff. Engaging family, if possible, for decision-making processes could actually work and not just the provider. And training parents and their teens to be vaccine champions, because we know that parents listen to other parents and their teens' experiences when it comes to the vaccine. One thing I really wanted to highlight is acknowledging the child's role. These are some quotes that parents stated that really resonated with me when it comes to working with parents and kids, is that, the kids, especially in the African American home, are actually playing a major role when it comes to decision making, whether they want to complete the vaccine series. And a parent actually said, well, I have to talk to my child first. I have to ask for his consent. He's always afraid of needles right from birth. And so to hear a parent say that, a lot of times we do not address the child when it comes to HPV vaccination, but it's so important that we engage children if necessary and have a plan for that in the protocol, if we want to increase likelihood of initiation and completion of this vaccine series. One of the last things I would like to end with is the recommendations for written materials. Very similarly, we have to make sure things are age appropriate for parent and child. A lot of times parents, African American parents, will like information that they could share with their child so that they can actually have a discussion about this vaccine prior to getting it. And so we have to make sure that this information is available. Particularly fifth to sixth grade reading level, being culturally sensitive is very critical. In terms of the materials, the graphics need to increase comprehension of both parent and child, reflect family, children, and vaccination, be age appropriate, bright colors. Parents said this all the time. Demonstrate processes, how vaccines work in the body. This was something very critical around the science. People wanted to understand the processes and how these vaccines were developed. and they wanted to be able to have an understanding so they can have that discussion with their child. In terms of evidence, they wanted it on the HPV and the vaccine, the clinical trial history of the vaccine, and present the vaccine safety profile and research history for children overall and by age and gender. So these are just some recommendations as we think about writing or developing new materials around HPV and vaccination. And also from the social-cultural context, again, very critical to have HPV vaccine providers and parents and children who are vaccinated to place a little testimonial in these materials so that people can really get an idea for what those experiences are. The other thing we've learned in terms of those experiences, even if it's not a positive experience, if something happened, whether the child may have fainted or whatever the case may be, parents want to hear all of that so that they can make an informed decision. And that creates that idea of transparency. It builds trust with the provider and the systems. So all of that is very important when we think about our materials as we move forward. So thank you. And I would like to leave you with this quote that I thought was very important during this time that we are in, is that at this critical moment, vaccine equity is the biggest moral test before the global community. Thank you.
That's a great quote and a huge call to action. Thank you so much. Thank you so much, Dr. Erves. What a great presentation. I love the interweaving of the personal quotes and the findings from research and just a lot of really practical information. And we will be sharing this on our website. We'll let you know via email to all the registrants when we get that posted live. So I'm going to get ready to turn it over to our next presenter. Our second presenter is Jennifer Hawk, who is the Associate Policy Principal for Access to Care at the American Cancer Society Cancer Action Network. ACS CAN, as many of you hopefully know, is the nonprofit, nonpartisan advocacy affiliate of the American Cancer Society. And Jennifer monitors and analyzes and makes recommendations regarding policies that affect patient access to care, survivor care, preventive services across the continuum, really. And these issues include things like insurance coverage and reform, Medicaid, healthcare costs, access to palliative care and pain management, paid medical leave and family leave, and just the impact of medical debt that is so rampant on cancer patients and survivors. And she's also the author of a great report. If you haven't seen it, you'll have to go to their website called The Costs of Cancer. That's an ACS CAN report. So let's go ahead and welcome Jennifer Hawk.
Okay, thanks everyone. And let me see if I can advance my slides. There we go. Okay, so I'm very excited to be here. I will say if I ever sound out of breath as I'm presenting, it's not because I'm excited, it's because there's a baby in here who's squishing my lung capacity.
Oh, congratulations.
So it's not that I've just run a marathon or anything. And I'll be okay. But I'm very excited to be here to talk about Medicaid. My charge today was to really talk about kind of Medicaid policies and how they interact with what we've been talking about with HPV vaccination and cervical cancer. So that's what I plan to do today. So as Katie mentioned, I'm the Associate Principal for Access to Care Policy with ACS CAN. We are the advocacy arm of the American Cancer Society. We have a presence in every state. So wherever you are, state and territory to some extent, wherever you are, we've got people there. We've got volunteers, we've got staff. We have people paying attention to what's happening in the legislatures and in the government, and pushing for, to end cancer as we know it. For everyone. So HPV vaccination is part of that mission. And I will also say, I mentioned I'm here mostly to talk about Medicaid because that is one of my policy expertises. But I am also here because another colleague is on vacation. So I want to recognize my colleague, Kathy Peters, who is the person who really follows the state and local legislation regarding HPV vaccination and kind of preventive services in general. So some of what I'm presenting today, came from her, and if some questions that I might not be able to answer, I'll have to refer to her, et cetera. So I'm kind of representing a broader team here on these issues. So we'll go ahead and get started. ACS can, one of the main things we think about when we are thinking about HPV vaccination is access to health insurance. And this pairs really well with the previous presentation, because she said, one of the most important things is having kind of the provider give the advice to the parent and the child that the vaccination should happen. Well, that it means that the parent and the child need to be in the doctor's office. They need to have a doctor that they can see, and they need to be in the office and an appointment for that kind of advice to happen. And then they get the vaccine. So all of that is mostly predicated on those folks having insurance. There are contexts in which you can get the vaccine outside of insurance, which the other Jennifer also talked about, with health departments, et cetera. But we really think that one of the most important ways to ensure that people can get their vaccinations is that they have health insurance coverage and they have access to it. And we know that from research. ACS and other researchers have shown very clearly that having health insurance equates to getting your preventive care and having better access to care. So I am mostly going to talk about Medicaid coverage, but I did also want to acknowledge one of the other big priorities right now for ACS CAN at the federal level is fighting for marketplace expanded subsidies. That is more relevant to conversations around coverage for adults than kids, because the bulk of the population we're talking about who need HPV vaccines are more in the Medicaid and CHIP population. But I did just want to mention we also have a major priority around getting expanded subsidies, which allow people to afford coverage through the marketplace, getting those to be made permanent because they do expire at the end of next year. So that's another federal priority for us. But mostly I'm going to talk about Medicaid here because Medicaid and CHIP, the Children's Health Insurance Program, insures around half of kids in this country. So I'm going to talk about a few kind of the major issues right now in Medicaid policy and Medicaid coverage. One is you've probably heard the phrase Medicaid unwinding. I think it's a really weird phrase that has somehow stuck. But what it really means is the process of unwinding the continuous coverage requirements that existed during the pandemic, the COVID-19 pandemic. States started that process last year and they are wrapping it up now. Some states have already finished their process. Some of them are still working through it. Most states are still processing appeals and backlogs and things like that. So it's not a done deal in pretty much any state. It's not a done deal. But states are in various stages of this unwinding process. The main point here is, so we have been very concerned before it started and as the process was happening, and still remain concerned that a lot of people have been dropped from coverage because of kind of procedural administrative reasons, rather than being dropped because they legitimately don't qualify for Medicaid anymore. There are people, who their income has increased or their coverage situation has changed, so they legitimately should not still be on Medicaid. So it makes sense to clean them from the rolls, and because they have coverage elsewhere or they don't qualify anymore. But a lot of people are being dropped simply because they never responded to a piece of mail they got. They didn't know they had to submit their information. all of these kinds of administrative hiccups that happen, especially when you're interacting with a population that is perhaps not used to dealing with insurance coverage. They are unaware kind of what the process is or how to get help. Maybe English isn't first language. There's all kinds of kind of access barriers. Another important point to realize is that children are more vulnerable in this process. The good news is that it is easier as a child to qualify for Medicaid or CHIP. The income levels for a child's family are higher than for adults in most cases. So it is easier to stay on Medicaid through this process if you're a child. The qualifications are, broader. So that's the good news. The bad news is, of course, that that child is probably not the one who needs to take the action to keep themselves covered. And so children are more vulnerable to being dropped from coverage because of these procedural issues, because they're not the ones filling out the forms and receiving the mail and keeping track of all this. It's the parents who are charged with doing this, and the parents might be being dropped because their income increased or their situation changed. So children are more likely to be eligible for Medicaid, but are also more likely to be disenrolled and to kind of be caught up in these problems with the process that we're having right now. The latest estimate showed that 5.13 million children have lost Medicaid as of May 2024, and many of them probably should still be on Medicaid, and this is kind of an administrative error. Some of them hopefully will make their way back to Medicaid over the next coming months and years, but that gap in coverage is really concerning, especially if we're talking about this specific vaccine, that it should be occurring at a specific time. If you miss that window of time, if that kid was uninsured, on their 9th birthday, they, miss that window, and are they going to come back and get the vaccine, catch up on the vaccine when they have coverage again? That's, it's harder to get them back in the office to do that. So here's state by state data. This comes from Georgetown, so this is not a map that I created, but this shows the distribution and kind of how each state is doing, because it's very different in every state. You'll see the glaring dark red of Texas and only slightly less dark red of Florida. I'll note that these are also states that have not expanded Medicaid, which I'm about to talk about. And as we know that, a lot of children have been dropped, particularly in Texas, from Medicaid. So that's a big concern. I also wanted to note that I saw this study too late to actually put it in the presentation, but there was also a recent journal article that came out showing that people of color are more likely to be dropped from coverage in this kind of administrative process of Medicaid unwinding, which is not entirely surprising, but they were able to show that in the data. Black and Hispanics were more likely to be dropped because of procedural issues. I also wanted to talk about Medicaid expansion, which is a major priority for ACS CAN. We had some action on that in 2024. There are 10 states who have not expanded Medicaid yet. Those are the orange states on the map. In 2024, we had very active campaigns in Georgia, Alabama, and Mississippi. Particularly Mississippi, we got really close to actually passing legislation that expanded Medicaid, but we didn't get it over the finish line. So in 2025, we are looking at those same 3 states. We have our eyes on them. Georgia, Alabama, and Mississippi all have, campaigns very active to expand Medicaid. We're also doing work in South Carolina, Kansas, Texas, and Florida to educate legislators and to collect stories to build campaigns and create kind of an active campaign. We are also watching Montana, which has to reauthorize their Medicaid expansion. And for all the states, we are looking into or we are watching out for work requirements, which is a policy that ACS can very strongly opposes, and we don't want work requirements muddying the waters. That is more of an adult issue than a kid's issue, so I'm going to speed past that because I'm running out of time. So I talked a lot about getting people on Medicaid or keeping them from being dropped off. I also wanted to mention some Medicaid policies, what happens once someone does have Medicaid coverage. From what I am told, it is not a huge issue of coverage of the HPV vaccine. It's pretty universally covered in Medicaid. So that is not the access barrier we're talking about. It's the other access barriers that were talked about in the last presentation, and actually getting people to be motivated to get the vaccine and to overcome kind of the access barriers to get themselves to the provider to get the vaccine. I said I was going to skip work requirements. Another policy that is some good news is there every state now is required to provide 1 year of continuous enrollment for children in their Medicaid program. So they can't recheck eligibility more than once a year. So if you get your child covered under Medicaid, they have that coverage for a year before they are checked for their eligibility again. So that is great in retaining and kind of providing continuity of care for kids. So in every state, they have to provide that for 1 year. Several states are starting to provide that for more than 1 year, so multi-year. There are several states who have submitted waivers and had them approved to cover children continuously from ages 0 to 5 or 0 to 6, depends on the state, what age we're talking about. That, of course, is before the HPV vaccine is delivered, but there are 2 states, Oregon and Hawaii, who have expanded in a target, or not expanded, who have changed their policy in a targeted way to allow children up to age 19 to have 2 years of continuous coverage. So again, that just kind of provides continuity of coverage for this population. And I also wanted to mention there's a lot of work going on in states on having Medicaid cover the work of community health workers and patient navigators. So those are potentially folks who can get the population to encourage them to, get their vaccines and get into the healthcare setting to get those. I also wanted to mention other policies that are directly related to the HPV vaccine, school requirements, and ACS can support school requirements for the HPV vaccine, ideally as part of a comprehensive school requirement for all of the recommended vaccines, so not singled out, but requirement for all of them. Under certain circumstances, you want the general rate to be high enough so that it's not you're catching the stragglers to get vaccinated rather than putting a mandate on a bunch of people who haven't been vaccinated. This is something that we support, but has not been super politically feasible. It's a tough environment out there for vaccine mandates right now. So I'm not aware of super active campaigns on this issue. Something that is a little more active is the second bullet here, which is states that are talking about exemptions for existing vaccine mandates. So ACS can supports eliminating any exemption that is non-medical. And we have been doing some work in certain states on that. Also, the previous speaker talked about pharmacists delivering vaccines. We do support laws that change that policy so that a pharmacist could deliver an HPV vaccine. And currently 34 states do allow pharmacists to vaccinate children as young as 9, so they could potentially deliver an HPV vaccine. So we do support those kind of scope of practice changes in states. It's another area that we have policy, we are happy to support it, but it's not super active right now at the state level. I wanted to mention those. And the last policy issue I will mention is we do have a major threat to all coverage of all preventive services right now, which is a court case that is working its way up to the Supreme Court. It's at the circuit level right now. It's called Braidwood versus Bacara. So some companies are challenging the validity of a particular section of the Affordable Care Act. And right now it's working its way through the legal process. So nothing has changed as of now, but it's possible, depending on how the courts rule, that they could get rid of the requirement in the ACA that requires private plans and Medicaid expansion plans to cover preventive services, which does, include the list of recommended vaccines. So that is a major concern for us, and we're watching that court case very closely. Opportunities for advocacy. I'm going to breeze through this because we're running out of time. My main message here is connect with ACS CAN staff in your state. We have them in every state. If you don't know your ACS CAN staffer, you might know your ACS staffer, and they can potentially make that connection. And sign up for emails, because those emails from ACS CAN are going to tell you exactly what is happening in your state, because they're very kind of localized to what the situation in the state is. And here's some other resources, but I'm going to stop talking. Thanks.
Thank you so much, Jennifer. That was super informative. And I know here in Kentucky, Medicaid was a game changer, and the thought of some of the advances going away is difficult to hear. But I want to take just a couple minutes for Q&A. While I'm talking, though, I am going to pull up that second poll while it's fresh in your mind. So please do look at the poll. But let's go to the Q&A slide. Just wanted to share with you the emails of everybody that spoke today, so that you can get in touch with us, ask questions. I also put down Gabby's email in case you would love to hear more about the roundtable through the National Roundtable. But let me ask a question, and I think it's probably for Dr. Erves. And it's what do you recommend coalitions could do to communicate with parents before they go to the health department, or before they go to those appointments? Are there effective ways that awareness campaigns can reach parents that you know of?
Thank you for that question. There are many ways I think you can reach parents, but the key behind that, first, I will say, is ensuring that you are a trusted messenger. I must say the countless of times I have taught with parents, and the key thing is not that they're getting information, they're having a hard time deciphering who they can trust and do they have the credentials to bring that information to them. Specifically when it comes to how to get the information to them. I think the social norm is partnering with other trusted messengers in the community to work to give information to parents. Schools are a great way to go, especially if your state will allow you to do it. I know, like, for example, in Tennessee, it was hard to get in schools to actually discuss HPV vaccination because it was not required. But a lot of parents are at school events. They're very much present after school, and that would be a great way to reach them. And we've seen in the literature, they're open to that. Another place to do it is working with providers. Providers can actually give information pre-visit. I just completed a study where we sent it out through the EHR. So helping them form what that information would look like could be great. The other part, providers, and doing some interviews with them, they are open to suggesting or recommending parents to talk to vaccine champions. So if parents could be vaccine champions and working to form that providers can link parents to, I think that would be another way you can go in terms of getting education to parents. So those are just a few things that you can do, but I think there are a lot of other things, partnering, especially in African American communities, faith-based organizations. I know that's the way we go to all the time, but the reality of it is they can get the information out. Other CBOs that work in health equity initiatives, they can help as well. So those are just a few options
Yeah.
in terms of getting education out.
That's awesome. So important to be reminded that it's the trusted messengers who need to be bringing that information. One question for Jennifer Hawk. What do you think the role of a state coalition is in some of these big P policy? If it's a government funded coalition, for instance, if they're based out of a health department, just how do folks advocate if they can't necessarily lobby?
Yeah, that's always a challenge. One way is to do it on, do it on your own time. Use your personal email to sign up for all these things. I do like to point out, you can still educate lawmakers and general public. And I do like to point out to audiences like this, when we're talking about advocacy, we talk about change coming from the grassroots, but we also talk about grass tops, and you all are grass tops. You are experts in your field. You know about vaccines, you know about public health. You probably have letters after your names with degrees and things. Those are people that our ACS CAN advocates really appreciate having along to help educate lawmakers. So I think, to the extent that you have comfort and are able to get involved in your professional capacity, you can be really valuable, even if you're not saying vote for this bill. If you're going in and saying HPV vaccination is really important because of this, and these are the patients I interact with, that is very helpful. Someone else can then say, and this is why, you need to vote for this bill.
Thank you, Jennifer. Last slide. Thank you both, Dr. Erves, Jennifer Hawk, for your time today and your expertise. And this last slide, I want to do a teaser for upcoming webinars in this series. The American Cancer Society continues this Comp Cancer series. How can cancer coalitions help achieve equity in cancer care? And our next one will be July 10th. We're going to talk about lung cancer stigma, how it's a barrier to care. And then in August, we're going to talk about non-invasive CRC screening and how that can improve rates in hard-to-reach populations. So I just thank you so much, everyone who logged in today, for sticking it out with us, taking the poll. Wish we'd had more time for questions, but the information was great, and we will be sharing it readily following this call. So have a great afternoon, everyone.